Good afternoon. My name is Nancy Trick, and I'm the Manager of Clinical Education at Teleflex. On behalf of Teleflex, thank you for joining us for the second of a two-part series of webinars focusing on the risks and management of catheter-associated thrombosis. Following our presentation, we welcome your questions. Please enter your questions on the questions section of the GoToWebinar panel. The title of today's webinar is Clinical Consequences Associated with Catheter-Related Deep Vein Thrombosis. Speaking on this very important topic are two leading experts, Drs. Caprini and Camorota. Dr. Joseph Caprini is a Louis W. Bigler Chair of Surgery in the Division of Vascular Surgery, North Shore University Health System, Evanston, Illinois, and Clinical Professor of Surgery at the University of Chicago, Pritzker School of Medicine in Chicago. Dr. Caprini is the author or co-author of many articles, including 350, as well as abstracts, and has presented more than 1,470 lectures and 91 exhibits on topics related to venous thromboembolism and venous insufficiency. He is published in the top medical journals in his area of expertise, including the Journal of Thrombosis and Thrombolysis, Archives of Internal Medicine, Journal of Arthroplasty, and Journal of Vascular Surgery. Dr. Caprini sits on the editorial review board of 6 medical journals and is a reviewer for 16 journals in total. Anthony James Camorota is an adjunct professor of surgery at the University of Michigan School of Medicine, Ann Arbor, Michigan, and is the director of the Jobs Vascular Institute, the Toledo Hospital, Toledo, Ohio. Dr. Camorota holds several senior positions in the ProMedica health system. He is the recipient of several honors for his teaching and clinical work, and has authored nearly 200 papers, 7 books, and 135 book chapters in areas related to vascular surgery. This webinar has been approved for 1 contact hour. Upon completion of the course, you will receive instructions regarding your certificate. Further instructions will be given later on in this webinar. Please join me in welcoming Dr. Camorota as we learn more about clinical consequences associated with catheter-related deep vein thrombosis.
Well, thank you, Nancy. Good afternoon, everyone. That is for those of you in the Eastern time zone, and a late good morning to all others. I have no reported conflict of interest related to this presentation. And the learning objective of today's program are that at the completion of these presentations, you should be able to describe the association between catheter-related thrombosis and bloodstream infection, to discuss the clinical consequences associated with upper extremity DVT and its impact on patient outcomes, specifically infection, pulmonary embolism, pulmonary hypertension, paradoxical stroke, superior vena cava syndrome, and post-thrombotic syndrome of the upper extremity. The purpose of the first portion of this program is to recognize the strong connection between infection and thrombosis. Years of research and clinical observation have shown that thrombosis begets infection, and infection begets thrombosis. In the next 20 minutes or so, I will show experimental data. I'll show you visual observations of bacteria using scanning electron microscopy, as well as numerous clinical studies supporting the relationship between thrombosis and infection. Mohammed and colleagues performed a series of experimental studies and showed that adsorbed blood components on prosthetic surfaces facilitate adhesion and colonization of bacteria. And they used indium-labeled bacterium, basically Staphylococcus epidermidis, that sequestered to the adherent thrombi. And you will see scanning electron micrographs showing the staph epidermidis adherent to the fibrin. That is, they were not passively trapped by a fibrin mesh, but the bacteria themselves adhere to fibrin strands. They demonstrated that platelet deposition on intravascular prostheses increases over time, as you can see. And when indium-labeled bacteria were infused, they adhered to the prosthetic surface at exactly the same rate as platelets. Of course, platelet deposition in these experiments was a marker for thrombus formation. So the question was then asked if platelets were inhibited using pharmacologic platelet inhibition, or if thrombosis was prevented with anticoagulation, would bacterial adherence be reduced or would it be avoided? And indeed, that was the case. There was a profound effect of platelet inhibition and anticoagulation on bacterial adherence. Bacterial adherence was nearly eliminated in this short-term experiment by platelet inhibition and by anticoagulation because no platelets were adhering and no thrombus was forming. Here is one of the scanning electron micrographs that I referred to earlier, and on this scanning electron micrograph we see bacteria adhering directly to the fibrin strands. On this second SEM, this shows us very clearly that indeed the bacterium themselves are specifically adherent to the fibrin strands that were present and nowhere else. The question is there a clinical correlation? One of the early studies to suggest a strong relationship between thrombus formation on catheters and bacterial contamination was performed by Stillman and his colleagues when they looked at central venous catheters, 94 of them, and performed culture and sensitivity examinations and inspection for thrombus when those catheters were removed. Now, the catheters were removed only when they were no longer needed, or if they were thrombosed, or of course at the time of death, which was rare. It's important to recognize that none of these catheters were removed for evidence of infection. None were removed for evidence of sepsis. And what they found was that 11 of the 41 catheters with thrombus had bacterial contamination, while none of the catheters which were free of thrombus had positive cultures. So in essence, 100% of the culture-positive catheters had thrombus in the catheter itself. Rad and colleagues studied the relationship between the thrombotic and infectious complications of central venous catheters in cancer patients. They looked at a 16-month study period in 72 cancer patients, and pardon me, they observed catheters sheathed in fibrin and that the staphylococcal bacteria adhered to the fibrin and actually produced enzymes that promoted thrombogenesis. In 23% of the patients with catheter thrombosis, septicemia developed, whereas no patient whose catheter was thrombus-free developed septicemia. Now, these are nearly identical observations to those reported by Stillman. So septic thrombosis is actually synergistic, but it didn't necessarily occur in all cases. Timsit and colleagues studied central vein catheter-related thrombosis in intensive care patients. And this was a study extended over 18 months with 208 central vein catheters, either in the jugular or subclavian vein. And all of these patients had a venous duplex examination performed within 24 hours prior to catheter removal. The mean catheter duration was 9 days. And they found that 1/3 of the catheters thrombosed during this study period. They demonstrated that the relative risk was substantially increased when the patients had the internal jugular route with a relative risk of thrombosis of 4.13, as you can see. Older age, that is those over 64, more than doubled the relative risk of thrombosis, and catheter-related sepsis increased 2.6-fold higher than when thrombosis was not present. Therapeutic heparinization significantly reduced the risk of catheter-related thrombosis. Crowley and her associates performed a prospective observational study to determine the incidence of thrombosis in patients with central venous catheter-associated infection with staph bacteremia. So they sought to evaluate thrombosis resulting from infection. Additionally, they wanted to evaluate the utility of physical examination for diagnosing upper extremity or neck venous thrombosis. And we know from past experience the physical examination for lower extremity DVT has not been that sensitive. Well, they looked at 48 consecutive patients with catheter-associated bacteremia in the central venous catheters, and all of the patients had venous duplex ultrasound and a physical examination, and the average outcome was assessed at 12 weeks. And they showed that thrombosis, which was identified by ultrasound, was present in 71% of the catheters with infection. Death or recurrent bacteremia occurred in 32% of those patients with thrombosis, whereas the same outcomes, death or recurrent bacteremia, occurred in less than half, that is 14%, without thrombosis. As one might predict, the sensitivity of the physical examination was poor at 24%, and only those patients that had engorged hand veins when the hands were elevated was their physical exam evidence did it substantiate proximal deep venous thrombosis. So their conclusions were that thrombosis is a common complication of catheter-associated bacteremia with Staphylococcus aureus, and that patients with Staph aureus bacteremia should undergo venous ultrasounds to rule out thrombosis. Thornburg and his colleagues then assessed the association between thrombosis and bloodstream infection in neonates with peripherally inserted catheters. So these were newborns in the neonatal ICU to once again determine the association between catheter-associated bloodstream infection and then subsequent thrombosis. And this was a robust study over 3 years. 1,500 peripherally inserted catheters and over 880 infants in the neonatal intensive care unit. And you can see the direct association between thrombosis and bloodstream infection in this robust study. The rate of infection is as recorded here, 13.2 per 1,000 PICC line days, and the rate of thrombosis was 8.9, essentially 9 per 1,000 PICC line days. So the association of thrombosis and infection was significantly more common than just thrombosis alone, as you can see from these data. So they concluded that there was this significant positive association between thrombosis and infection in infants who had their lines removed. So von Ruden and colleagues also studied whether infectious complications of central venous catheters increase the risk of catheter-related thrombosis in hematology patients. And this was a prospective study, and they also studied whether thrombosis can be predicted by surveillance of their CVC lock fluid. That's the fluid that locks into the hub of the central venous catheter. So this was a nicely designed prospective study, 105 consecutive patients. They were examined for CVC thrombosis, all had the microbial surveillance of the CVC lock fluid every other day. And if there was a clinical suspicion of thrombosis, a venous duplex ultrasound was performed. So they demonstrated that CVC-related infection occurred in about a quarter of the patients. And there was clinically manifested thrombosis in 12% of the patients. So the odds ratio then calculated that the odds ratio of thrombosis with infection was 17.6, which is a very robust association. But what's quite remarkable is this last bullet point. So it's quite interesting to see that in patients who had 2 positive cultures or more, that thrombosis occurred at 71% versus only 3% thrombosis occurring with a negative single or a single positive culture or no positive cultures. So their conclusions were that the risk of clinically manifest thrombosis increases significantly after CVC-related infection, and surveillance culturing CVC lock fluid may indeed be useful. So I'd like to finish up by summarizing a literature review of 48 selected patients comparing peripherally inserted central venous catheters versus centrally inserted catheters to determine basically if PICC lines were superior to the more centrally placed catheters. And the authors summarized this review of nearly 50 papers by concluding that infectious complications were essentially no different between PICC lines and centrally inserted central venous lines. That thrombotic complications are actually more significant with PICC lines and appear earlier after the catheter is inserted, and that prospectively, when PICC lines are observed, approximately 40% of these PICC lines will have to be removed before the target date of completion therapy, the target for their therapy to be completed. So in conclusion, ladies and gentlemen, there is a strong interrelationship between thrombosis and infection. Thrombus significantly lowers the threshold for bacterial colonization, and infection stimulates thrombosis. So therefore, measures to prevent thrombosis indeed will prevent infection. And as we have seen, peripherally inserted central vein lines have the same infectious complications, but higher thrombotic complications as centrally inserted lines. So the first portion of this presentation is now complete, and I'd like to turn over the remainder of the formal part of this program to my colleague, Dr. Joseph Caprini, who will review.
Slides are up.
Who will review with you the non-infectious complications of catheter-related thrombosis. So please stand by as we transition to the slides of Dr. Caprini.
Thank you very much, Tony. While the slides are coming up, it's a fascinating thing, these data you presented and showing the interrelationship of infection and thrombosis, and I think all of us have to think a whole lot differently about this problem and the problems associated with infection. And I think that was just a really interesting summary of the interrelationships between the two problems. The clinical consequences associated with patient outcomes are many, and I'd like to begin by, first of all, again, adding my thanks and welcome to all of you for participating in this program and for the pleasure of being able to do this program with my esteemed colleague, Dr. Camorota. And let us start talking about the many faces of venous thromboembolism. Unfortunately, sometimes people don't think about all of these different problems when they talk about thrombosis. And especially with upper extremity thrombosis, there are a number of problems that I would like to emphasize at this point. And those include both the pulmonary emboli and the very interesting association between paradoxical emboli, between patent foramen ovale and paradoxical embolus producing stroke, the superior vena cava syndrome, which is a uncommon but very nasty complication, especially in tumor patients, the post-thrombotic syndrome, which is an absolute nightmare for lower extremity deep vein thrombosis. We don't know that much about upper extremities incidents, but we'll discuss those issues, and also the problems associated with the systemic anticoagulation. Pulmonary emboli are responsible for 300,000 deaths probably in the U.S. in a recent year, and a third of them occur on presentation. So it's indeed a major problem. And pulmonary embolism, of course, results when there's a blockage in the pulmonary artery, excuse me, in the lungs by fat air, blood clot, or tumor cells. It's difficult to determine the true incidence of pulmonary embolism. You can't run around doing a screening CAT scan on everyone. And in addition to that, catheter-related thrombosis from upper extremity central venous catheters is often, or PICC lines, is often asymptomatic. And if there is a borderline pulmonary reserve, then it is more likely that a person will experience clinical symptoms from the pulmonary emboli. The removal of the catheter has many implications in association with pulmonary emboli. For example, part of a mural thrombus can break off, or as you're pulling the catheter out, fibrin may be stripped from the catheter. And these are generally small thrombi, but it is possible that even these small thrombi could cause a serious problem. And I'm thinking here of, again, the paradoxical embolus. If there is a patent foramen, we'll discuss that in a minute, then even a small clot could pass over to the systemic circulation and produce a very significant stroke. It is also possible that forced expulsion of interluminal contents of the central venous catheter by irrigation can also produce these embolic problems. Here we see a beautiful picture from my colleague, Dr. Camorota, of a central venous catheter thrombosis. And these thrombi in the deep venous system of the upper extremity may be associated with a pulmonary embolism rate of 12%, which is certainly not insignificant. Hingarini and colleagues have performed an interesting study comparing upper extremity and lower extremity venous thrombosis. And of course, many of us feel or have felt in the past, or it's a general feeling, that upper extremity venous thrombosis is relatively benign compared to lower extremity deep vein thrombosis. So this study was an initial attempt to compare the impact of upper extremity to lower extremity venous thrombosis on morbidity and pulmonary embolism in particular, as well as mortality. This study was a retrospective review over an 18-month period and involved 52 patients with upper extremity venous thrombosis and 430 patients with lower extremity venous thrombosis. VQ scans were performed for clinically suspected PE. The results indicated that 17% of people with upper extremity venous thrombosis and 8% of those with lower deep vein thrombosis were associated with pulmonary emboli, which was a surprising figure. Equally surprising was the mortality rate in 6 months of 48% from upper extremity venous thrombosis compared to 13% for lower extremity. And here is a view of the curves. The life table analysis in these patients. And the authors concluded that upper extremity thrombosis was indeed associated with a higher morbidity and mortality than was previously expected. And of course, upper extremity venous thrombosis was also in this study an unrecognized predictor of morbidity and mortality. Now, before we take all of this to the bank, I'd like to point out to the audience that this is just one study. It hasn't really been confirmed in other studies, and the importance of the study is not so much even in the exact numbers. The importance of the study, as far as I'm concerned, is for us to realize that upper extremity venous thrombosis is a serious problem and that it may be associated with serious morbidity and mortality. Here is an interesting picture from the inside of the right atrium of a patent foramen ovale with a clot in the patent foramen. And if you will imagine for a minute that a person has a thrombus in the upper extremity or lower extremity. It goes to the right atrium. It dilates a non-functioning patent foramen, making it big enough so a clot can get through it or stick in it. Then it is possible for that clot to get into the arterial circulation, and the most common and likely place for it to go is to the brain and produce a non-hemorrhagic stroke. It is possible for it to go to the systemic circulation, but that is relatively rare. Hankey, in the New England Journal article several years ago, pointed out to us that a patent foramen ovale is present in 27% of the general population at autopsy. So 1 out of 4 people is walking around with this. It's greater among patients with cryptogenic stroke than among those of stroke of known causes for both younger and for older patients in several series. And among younger and older patients, the PFO is also more prevalent with other causes such as atrial septal aneurysm and, again, as I said, cryptogenic stroke. So that when you see a cryptogenic stroke, it's not. It's very likely that that patient has a patent foramen, but they're not necessarily related. It may be a true unrelated situation. The most important thing for a person to remember, and as far as I'm concerned, is that when you do see a cryptogenic stroke, don't rule out venous thrombosis as a possible etiology. That's the take-home message, I believe. Here is an interesting case of a 46-year-old male in ICU who had a central venous catheter placed in the right internal jugular. On the 4th day, he became unresponsive. A CAT scan showed cerebral infarcts. Doppler ultrasound revealed a right jugular venous thrombosis, while the transesophageal echo revealed a patent foramen ovale. The patient was treated with anticoagulants for 3 months and suffered minimal visual and physical disabilities. Here is another patient, 61-year-old diabetic male with a dual-chamber pacemaker. 6 weeks afterwards, he presented, after the pacemaker was placed, he presented with confusion, fever, leukocytosis, and no evidence of a pocket infection. 24 hours after admission, he became lethargic, developed right hemiplegia. A CAT scan revealed embolic frontal hemispheric event in the brain. A diagnosis by transesophageal echo showed a septic paradoxical embolus through the patent foramen due to infected pacemaker lead. Now, I don't want you to think that these are everyday occurrences with upper extremity catheters, but just keep in mind that when faced with a cryptogenic stroke, please think about deep vein thrombosis or upper or lower extremity. Another uncommon but important issue is the superior vena cava syndrome. And this occurs with impedance of blood flow in the superior vena cava, either by extrinsic compression, which would usually be a tumor, or interluminal narrowing. Impaired blood flow from the face, neck, upper extremities, and upper thorax results, with the result of the development of symptomatology including venous distension of the upper chest, neck, and face, development of collateral circulation, swelling, which may be seen in the face, neck, or upper extremity, a dry productive cough, feeling of fullness in the head, or dyspnea, dysphagia, or chest pain. Superior vena cava syndrome affects nearly 15,000 patients in the U.S. annually. It's generally caused by cancerous tumors, and 87 to 97% of superior vena cava syndrome patients are caused by mediastinal malignancies, such as lung cancer, lymphoma, and breast cancer. Increasingly common causes, however, are thrombosis due to CVC catheterization or pacemaker placement. 7% of the superior vena cava syndrome cases were caused by long-term central venous catheters. An example of this problem is seen in this patient who had a history of a narrowed superior vena cava noticed at the time of venography. Nevertheless, a Hickman catheter was placed with its tip in the superior vena cava. Immediate severe respiratory compromise requiring intubation was observed, and the catheter was removed and the symptoms resolved. This was thought to the patient was thought, therefore, to have an acute airway obstruction secondary to superior vena cava obstruction. It's another important consideration, I don't have a slide on this right now, which was recently reported, is catheter size may also be important. Oftentimes we put in large catheters to get good flow, but those large catheters can obstruct the venous system, and so if there's any degree of obstruction to begin with, this will maximize those problems. A literal nightmare for deep vein thrombosis of the lower extremities is the post-thrombotic syndrome. It's a chronic, debilitating condition that occurs up to 25 to 50% of people with a lower extremity DVT. But what isn't realized is that up to 44% of patients with an upper extremity DVT also can suffer from this symptomatology. It's not nearly as disabling or as dramatic as it is in the lower extremities. It can occur months or years after a thrombosis has been present. And it's usually caused by residual thrombus and valve injury. As you can see here is a very beautiful picture of a stasis behind the valve cusps, and also there is evidence of a mural thickening of the wall in this particular vessel. Symptoms in this condition include residual edema, pain, numbness, heaviness in the affected extremity. And this results in functional limitations, as you might imagine. And it's very important to recognize that there is a poorer quality of life if the patient is experiencing this problem in their dominant side. So it's very, very important for the clinician to keep in mind and query the patient about their dominant extremity before placing catheters. The clinical impact of the post-thrombotic syndrome is seen in this slide, where we see in a small study of Prandoni's 44 patients with a PICC line-related DVT, and 1/3 of the patients with upper extremity DVT had mild arm pain, 1 with moderate pain, and none with severe pain. So it would appear, and this is a very small study, that in this particular series and for this particular problem, it's not quite the issue it is with the lower extremity. A meta-analysis of 7 studies by Ellman looking at PTS after upper extremity DVT revealed that the frequency varied between 7 and 46%. And of course the reason for that is that it's very difficult to really, what are the diagnostic criteria, the specific diagnostic criteria that have a sine qua non for post-thrombotic syndrome? We don't know. There are various ways we look at that, so that the incidence varies widely, and that's not a surprise. There's an increased risk of PTS if there's an axiosubclavian thrombosis or residual thrombosis on the ultrasound after the catheter is removed. Here is an interesting study by Susan Kahn, who's one of the real prominent and important investigators of all time as far as the post-thrombotic syndrome. She's a hematologist, which is devoted, and she has devoted a great time of energy and time and interest in the post-thrombotic syndrome. And in her analysis that was reported in 2005, ipsilateral hand swelling was seen in 52% of the patients, arm pain in 20%, and 11 out of 24 patients and 25 limbs altogether had the signs of the post-thrombotic syndrome. 1 with a severe disability. This seems to go along with the results of the Prandoni study. And when compared with patients without post-thrombotic syndrome, there was much more functional disability and poor quality of life. And of course, this was most evident when the dominant arm was involved. The treatment of post-thrombotic syndrome is also a subject of debate and controversy. Early catheter removal certainly would reduce the incidence of post-thrombotic syndrome. We know that in the lower extremity, the use of thromboembolic stockings dramatically decreases by a factor of almost 50% the incidence of post-thrombotic syndrome after 2 years when these stockings are of sufficient strength and worn for a sufficient period of time. But we don't know about the upper extremity. We feel it's important to use graduated compression sleeves for all patients with symptoms in the upper extremity, and this may help to prevent development of chronic venous insufficiency, especially in younger patients. I've also found that manual lymph drainage in some of these patients can be very helpful. Anticoagulation. This is a huge topic for upper extremity venous thrombosis. Treatment plans vary based on patient factors and conditions, such as platelet count, recent surgery, upcoming surgery or procedures, patient compliance with warfarin, for example, and the need for future dialysis. And it's very important for clinicians to have considered, prior to placement of the line, the need for dialysis. Different practitioners vary on the treatment. Consideration is also based on the type of thrombosis, complete versus partial, deep, as in an axillary or subclavian, brachiocephalic, or superficial, as in basilic, brachial, or cephalic on the more peripheral clots. There's no one approach to the treatment of thrombosis in the upper extremity with lines. The one comment I would make that I feel is very important in clinical practice is that if a patient has a catheter-related thrombosis and the catheter is still able to function, then they should be treated, and the catheter, in my opinion, should be left in place, because if you pull the catheter, now you've got access problems, and if you put the catheter in a new location, you're likely to get another thrombosis. Lincolns and Associates took a look at the clinical impact of bleeding in patients taking oral anticoagulant therapy for venous thromboembolism. The purpose of this study was to try to estimate the amount of anticoagulant-related bleeding, including case fatality rates and intracranial bleeding. And in this particular study, there was a focus on non-cancer patients. 33 studies with 4,300 patients were examined. And as you can see here, there is a not insignificant incidence of both bleeding after anticoagulation, as well as case fatality and 1% or more incidence of intracranial bleeds. And 1% may not seem like a lot, but would you take your next airplane flight if you knew 1% of them would crash? One lady told me once, it all depends on where the plane's going. Nevertheless, the clinical impact of bleeding in patients taking oral anticoagulant therapy is important. Major bleeding may be increased, although infrequent, and death could occur in these patients who develop a major bleed while on warfarin. Now, that was mostly with the non-cancer patients. Cancer patients require low molecular weight heparin, as we'll see in a minute, due to the lower incidence of recurrence and also the occurrence of bleeding in these patients. As the cancer disease progresses, so do the hazards of anticoagulation. You know, cancer patients, the second leading cause of death in cancer patients is thrombosis, and one of the major causes of decreased quality of life in the cancer patient is significant thrombosis. Cancer patients have a threefold higher risk of recurrence of venous thromboembolism, a twofold higher incidence of bleeding than patients without cancer. But let's face it, cancer patients clot more and they bleed more than patients without cancer with equivalent problems. Here's the landmark study comparing low molecular weight heparin to warfarin for the treatment of deep vein thrombosis in patients who have active cancer and who have developed an acute thrombosis. This is by Agnes Lee in 2005, and what she did was to investigate two regimens in the cancer patient. Regimen number one, was a single dose of low molecular weight heparin given daily at 3/4 dose and then full dose after a month for 6 months. And this was compared to a low molecular weight heparin in the treatment dose for 5 days as a bridge to 6 months of warfarin. Here we can see the incidence of recurrence in the warfarin group is twice that of the low molecular weight heparin group. It's around 15% compared to 6.5%. And this is over a 6-month period. The incidence of bleeding, with the low molecular weight heparin, there was more major bleeding, but overall, any bleeding, there was more with the warfarin. But these numbers weren't statistically significant, and as I said before, is that cancer patients bleed more than non-cancer patients, regardless of the anticoagulation employed. So in conclusion, there's a close association between catheter-related thrombosis and infection. Upper extremity central vein catheterization is associated with a greater incidence of PE and mortality than previously expected. Individual patient predisposing conditions are impactful as to those who develop upper extremity venous thrombosis, including patent foramen ovale, and I have to throw in here the beautiful presentation of my colleague about infection and the relationship to venous thrombosis. Thrombosis with malignancy is associated with a high morbidity, particularly if the superior vena cava syndrome is involved. The consequences of upper extremity deep vein thrombosis can have life-altering effects on patient outcomes, particularly the post-thrombotic syndrome, especially and most importantly if it occurs in the patient's dominant arm. The following is a bibliography that relates to these presentations. And at this time I would like to say that this is a CME approved program, and to obtain one hour, please go to www.saxtesting.com/VH. Complete the post-test and evaluation form. A certificate of completion will be issued immediately, and this is provider approved by the California Board of Registered Nursing, provider number 14477. Now I would like to open this up to questions.
Very good. Thank you, Dr. Caprini and Camorota. We have several questions that one or both of you may feel that you have answers to. The first question comes with regard to heparin flushes and significantly increasing the risk of thrombocytopenia. And this individual is looking at changing their current policy regarding routine flushes with heparin, and they are asking for your comment and opinion on that type of protocol.
Sure, that's a pertinent question today, because we know that heparin-induced thrombocytopenia is a common complication, certainly not a rare complication with the use of unfractionated heparin. We know that it is not a dose-related complication, so small doses that occur with heparin flushes can also stimulate heparin-induced thrombocytopenia, and HIT, when it occurs, is associated with substantial morbidity, and it is a thrombotic complication, so you'll have both arterial and venous thrombotic complications. We have abandoned all heparin flushes in our institution. I know many institutions have done the same thing, and I think it would be worthwhile if you also followed suit, just because we are looking at, in real numbers, about a 3 to 4% risk overall. Certain patient groups are higher, cardiothoracic patient groups, perhaps orthopedic, but in general, it would be a good policy to adopt.
Tony, I couldn't agree with you more.
Okay. Dr. Caprini, you mentioned in your presentation the effect of the physical properties related to different disease processes, as well as mechanical difficulties such as patent foraminal valley. And there's a question here that runs along those same lines in terms of the mechanics, and that is your opinion regarding the diameter of a vessel relative to the gauge size of a catheter, and if there is greater risk for larger catheters and smaller vessels, and also if there is greater risk at the tip of the catheter depending on where it's located within the superior vena cava.
That's a very good question. It sounds like it was written by the author of a recent article that emphasized the importance. This was an engineering study that emphasized the importance of catheter diameter, and as I sort of alluded to, large catheters are often preferred because they give good flow rates, and the trouble is that the relationship of the catheter size to the catheter to the vein wall is extremely important, and these larger catheters in smaller veins may actually cause obstruction and increase the incidence of thrombosis. And the same holds true for the position of the catheter within the vessel, so that I think that I believe this was in Chest recently, and there was an editorial by Sam Goldhaber on this, and it's an extremely important consideration. And in fact, the title of the editorial was "Bigger is Not Always Better." So I would encourage the audience to take a careful look and evaluate catheter size versus vein size in the selection of their catheters for central venous placement.
In your review of the literature, do you see the observation that patients are at greater risk for thrombosis with catheters where the tip is higher in the SVC, lower, or in the right atrium?
I'm going to defer to Dr. Camorota on that one. What do you think, Tony?
Sure. Generally speaking, we like to get the catheter tip into or very close to the right atrium. Generally speaking, if the tip is riding up against the SVC and it doesn't take the curve around, there's not only mechanical trauma but more chemical trauma of the infusate. So I think catheter positioning is important. The individual asking that question has a good intuitive sense, I'm sure, and that we can probably reduce the trauma to the SVC by having the catheter inserted a little farther, a gentle curve, and the tip in the right atrium or near the right atrium.
Mm-hmm. Relative to catheter tip positioning, the occurrence of thrombosis and infection, this is my question, by the way, it seems that we have in clinical practice addressed these problems individually, but they seem to have a tri-directional relationship. And I'm curious about how we can, from my perspective, we need to look at these as not a single situation, but rather situations that are interrelated. And when I make that statement, individuals will say, well, which comes first? And that's like asking, is it the chicken or the egg? So from your experience, is it first one or the other, or are we not far along enough in the process to really understand the morphology behind that?
Well, I think based upon both the larger clinical studies that we have as well as the experimental studies, we can't really separate the two. We've demonstrated that when thrombosis occurs first, there's a skyrocketing rate of infection. We also have shown that in catheters that are open who develop infection, the risk of thrombosis also skyrockets. So as I think my second slide summarized, thrombosis begets infection and infection begets thrombosis.
Mm-hmm. Right. Very definitely. One last question, and this has to do with catheter materials and the occurrence of either thrombosis or infection related to silicone, polyurethane, and other types of materials. And do you see any differences in the reported rates of thrombosis or infection with these devices? And lastly, what role does biofilm play in that whole paradigm?
Yeah, well, it's a very good question, and certainly, Joe, any thoughts that you have, I'd welcome them.
Sure.
I'm not sure that I can do justice to addressing the different catheter materials. Certainly, materials that tend to reduce thrombosis will reduce infection. The issue about biofilm is important because those bacteria that produce biofilm develop an impenetrable layer to antibiotics, and therefore antibiotics are ineffective because of the biofilm. So it has become an important issue, especially in the area of prosthetics that are implanted in our patients.
I don't think that you can emphasize too strongly the importance of the role of biofilm in this whole process. And I think that avoiding biofilm is critical, and I think that developing newer catheter materials that will make it harder for biofilm to proliferate is an important consideration.
Very good, very good. Well, on behalf of Teleflex, I'd like to thank both Dr. Caprini and Camorota for your important conversation, as well as pointing us to the facts around this matter. This has been a very productive session. I want to remind the audience that you may access your CEU information at vesselhealth.org, and we'll conclude this webinar. Thank you, and have a great day.